Darlene.
Hi, Darlene.
Hello.
Okay. And was that Tracy before?
I don't see Tracy online.
We're still waiting. Okay, we're still waiting for Tracy. Oh,
And
there
she
you
is.
go.
Hi, Gina and Karen.
Hello. Hi, Darlene.
Thank you both for doing this.
No problem. Ashley's also here. She's just on the phone line.
I'm on the phone. Unfortunately, a tree
Oh, hi, Ashley. Sorry,
fell on my road.
You. I always use the phone, and that way it prevents the phone from ringing in the middle of anything.
That's probably a good idea.
And when we're not presenting, will we be muted or?
No, you will be you'll be able to speak. So if you need to, if there's some back and forth going on, everyone will be able to hear you.
Okay.
If, however, there's some feedback from one of your mics, I do have the ability to mute from where I am in the office.
Okay.
I can certainly do that. Tracy's still coming on now, so I'll do a really brief introduction and just sort of go over the technical details. And then right at the end, I'll pass it off to Tracy, and she'll do the introduction for the all the presenters as well as the content today.
So the only thing I'm seeing on my screen now is a Windows icon. Is that what I should be seeing?
Yes, for some reason, I don't know why my screen isn't letting me show, because I actually have my browser up, and I'm wondering.
There it is.
Oh, flash for a minute.
And nothing now?
Just a blue screen is all I have.
That is so strange.
Name on my end. It's Tracy. I'm on call.
There, it's flashed again. Now it's a lighter blue screen.
Yeah, for some reason I'm having, I don't know why it's not picking up my, I'm going to try with Explorer. It might be because I'm using Chrome. Let's try this. I mean, I don't really have anything to show on my end. I have the Ken page up with the information.
So we're watching as you're logging in. Oh, there's the Ken.
Okay, so it was because I was using Chrome. Interesting.
Yeah, Chrome I find is usually better.
Yeah, it's giving me a bit of trouble today. Do this. I'm going to pull the Ken over. And you can still see it now?
Almost. It's not quite on the screen yet.
It's a little bit delayed. Yeah.
There you go.
Hi, I'm just on an
Great.
Oh, there. Ooh. Sorry, I'll stop making my noises.
No, that's okay. It helps me because I can't see what you're seeing, so that helps if you let me know. So does anyone have any last questions before we get going? I have 2 minutes to go on my clock.
Tracy, you're leading it today?
Pardon me?
Tracy's leading it?
Yeah,
yes.
I'm leading.
Okay, perfect.
So, Sam, are you actually bringing up the presentation?
I don't have anyone's presentations. I can give the screen over to the different presenters.
Oh, okay.
So I'm just going to be doing a brief technical introduction, and then I will pass the screen over to Gina for her. Well, I'll introduce you, Tracy. You're going to do the introductions for the different speakers and then for the content.
Okay.
And then do you have screens, any slides to show, or you're just going to be speaking?
Oh, no, I'm just going to talk.
Great. So then I will pass it over to Gina while you're speaking, and then she'll be ready to go when you're done.
Perfect.
And Karen and Ashley, I was just thinking if there's questions, I'll likely defer to you unless they're specifically directed at me, if that's okay.
Sure. Yep. I think we're good with that.
Great.
Gina, you might want to speak up a bit. You're a little.
Yeah, I have quite the case of laryngitis.
Oh dear.
My phone is on its max, but I'll try my best.
Okay, thank you. Sorry about that.
No, that's okay. Is this better?
Yeah, it is.
Okay.
All right, so I have 11 a.m. and if everyone's ready, I'm going to get started up here.
Sounds good.
Great.
The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. Welcome to CAFC's Patient Safety Collaborative webinar series. My name is Samantha Delanardo. I'm the program assistant here at CAFC, and I'm filling in for Lisa Stromquist. The Patient Safety Collaborative meets the fourth Friday of each month at this time for a presentation on innovative programs, research, or emerging issues in pediatric patient safety from one of our member organizations. Before we get started today with the presentation, I wanted to provide you with a few technical details. All the lines have come in muted, so there'll be no background noise to distract the presenters. However, we do encourage the audience to participate, and so you'll be able to do that. You'll notice a question box in the right-hand side of your screen in the control panel. As the presentation unfolds, feel free to write your questions in as they occur to you. They'll be answered at the end of the presentation during a designated question and answer session. We do have a poll question for the audience today, so when you have the opportunity, I'll briefly explain how to do it, but it's very simple. You're just going to click on the box and you'll be able to provide your answer to that. Like all of our presentations, this one is being recorded and will be posted on the CAFC Knowledge Exchange Network for viewing at a later time. As well as our patient safety presentations, CAFC also hosts CAFC Presents. It's a weekly webinar series with a wide variety of topics, and I encourage you all to visit our KEN website, the Knowledge Exchange Network, and to view our past sessions. So for now, I will hand the podium over to Tracy Rong. She's a Director of Quality and Safety at Children's Hospital of Eastern Ontario, CHEO, and she's the co-chair of our Patient Safety Collaborative. Over to you, Tracy.
Thank you very much, Sam. Welcome, everybody. So on behalf of my co-chair, which is Darlene Bolivar at the IWK in Halifax, I'd like to welcome you all to today's Patient Safety Collaborative session. Really excited about this, and this session is truly pan-Canadian, as our presenters are coming from Halifax, Nova Scotia, and from British Columbia. So good afternoon to the folks in Halifax, and good morning to the folks in BC. I would like to start off the session just with a brief introduction, and then we'll turn it over to the speakers very shortly. With antimicrobial resistance escalating at alarming rates and the dire concern that the world is heading towards almost a post-antibiotic era, implementation of antimicrobial stewardship programs have become so important that they've actually been deemed a required organizational practice by Accreditation Canada. Antimicrobial stewardship programs improve judicious antimicrobial use via coordinated interventions on appropriate selection, dosing, and route. Sorry, I've got overhead chatting at CHEO here. Dosing, route, and duration of antimicrobial therapy, and with the primary focus of optimizing patient outcomes, we aim to reduce the risk of infections, reduce or stabilize levels of antimicrobial resistance, and promote patient safety. So it's my pleasure today to introduce Gina Vanietti, who is a pediatric critical care pharmacist at the IWK Health Centre in Halifax, Nova Scotia. Also, we have Karen Ng, who has been an antimicrobial stewardship clinical pharmacy specialist at BC Children's Hospital since September 2013. And Ashley Roberts, who is the medical director of antimicrobial stewardship at the Provincial Health Services Authority in British Columbia, and that covers BC Children's Hospital, BC Women's Hospital, and the BC Cancer Agency. As Sam noted, you can see their bios on the Knowledge Exchange Network to learn more about them. But at this point, I'd like to turn it over to Sam and Gina will present first, and Karen and Ashley will follow afterwards. So over to you, Gina, I guess. Gina and Sam. We're going to just do that. There we are. Good.
Hi, we're good. Okay.
Excellent.
Hi, so as
Thanks,
Tracy.
Gina, over
yes?
to you.
Okay, great. So as Tracy said, my name is Gina Vanietti. I'm a critical care pharmacist at the IWK Health Centre in Halifax, Nova Scotia, and I'm slightly under the weather, so I apologize for my raspy voice, but hopefully we'll be able to get through okay. So before I hand it over to Karen and Ashley for their piece, I'm just going to go over the objectives for my part of the presentation. So Initially, we're just going to discuss what antimicrobial stewardship is for maybe those who are new to it, why it is so important with a small focus on the resistance, antimicrobial resistance, and then we're going to talk a little bit about stewardship programs and what's been done to date at the IWK with antimicrobial stewardship. So before we really get started, we wanted to do an audience poll just to see where people currently are with their antimicrobial stewardship program. So if you could plug in answers A through D, whether you have A, fully implemented stewardship program, B, if implementation is in process, C, if you're considering stewardship, and D, if you've not yet considered implementation.
All right, great. So we're just waiting for some answers to come in here. People a few more minutes. Not a few more minutes, a few more seconds. All right, so I'm going to close this poll and we'll show the answers here. Looks like about 67% said the implementation is in process, followed by an even 13% for the fully implemented ASP, and they're considering ASP, and then we have 7% who have not yet considered it.
Okay, great. So it sounds like most people are at least, you know, have it implemented, undergoing, considering how things are done, which is really great to see. So I'm just going to go right into the presentation and just talk about what antimicrobial stewardship actually is. So it's actually a little bit to define stewardship because it can really look like a lot of different things. So you could think of it as being an evidence-based program that utilizes a systematic approach to the use of antimicrobials in order to ensure optimal patient outcomes. But really, it's probably more easily defined by its goals. So in 2007, the IDSA and SHAES, the Infectious Disease Society American Society of Healthcare Epidemiology of America, they published guidelines for developing an institutional antimicrobial stewardship program. And these guidelines state that the primary goal of antimicrobial stewardship is to optimize clinical outcomes while minimizing unintended consequences of antimicrobial use, including toxicity, the selection of pathogenic organisms, and the emergence of resistance. A secondary goal outlined in these guidelines is to reduce healthcare costs without adversely impacting the quality of patient care. So in other words, antimicrobial stewardship is really aiming to promote the appropriate use of antimicrobials. So this would be the right drug, dose, duration, and route of administration. So when we're looking at the right drug, we want to be asking ourselves questions like, does the patient even need a drug? Is the spectrum of therapy too broad? Could we be minimizing it or reducing the number of antimicrobials the patient is receiving? Have we reassessed their therapy after cultures have returned? Looking at the right dose, have we treating too high or too low depending on the indication or the causative organism? Have we ordered drug levels and assessed them to see if they're appropriate? For duration, does the antibiotic need to be continued or could it be stopped or at least stepped down from IV to oral so that maybe these patients can get home a little bit sooner and avoid some of the potential complications of having IV access? So now that I've kind of gone over what stewardship is and some of the goals of it, why has this become so important? So in 2008, the Clinical Infectious Disease Journal published an article that reported that as much as 50% of hospital antimicrobial use is unnecessary due to treatment of contaminants, overly broad coverage, or prolonged treatment. And all of these things can lead to the emergence of antimicrobial resistance. So this really poses a serious health threat to the entire population, especially hospitalized patients, because we know that patients that have infections due to antimicrobial resistant organisms have a significant increase in both morbidity and mortality, which leads to increased length of hospital stay and also healthcare costs. Last is a study published in Clinical Pediatrics reported that antimicrobials are the class of medications that are most frequently associated with med errors in the pediatric population. So improving antimicrobial use really is a medication safety and a patient safety issue. And throughout North America, healthcare facilities have been encouraged to implement antimicrobial stewardship programs, and Accreditation Canada, as I'm sure you're aware, has now made antimicrobial stewardship a required organizational practice. So there's been an increasing amount of literature regarding antimicrobial resistance over the past several years through organizations like the WHO, CDC, and so on. So inappropriate use of antimicrobials can lead to resistance, and this is really what makes antimicrobials unlike any other drug, because their use in one patient can compromise their efficacy in another. In a 2008 report, the WHO identified antimicrobial resistance as a public health threat and the third most important patient safety challenge, and this was behind only hand hygiene and the surgical safety checklist. So recognizing that antimicrobial resistance is an increasingly serious threat to global public health, the WHO decided that determining the scope of the problem really has to be their first step in formulating an effective response. So it produced this report, Antimicrobial Resistance, the Global Report on Surveillance 2014, and this was really their first attempt to attain an accurate picture of the magnitude of antimicrobial resistance and the current state of surveillance globally. So the WHO obtained from 114 member states the most recent information on resistance surveillance and data for a select set of 9 bacteria, antibacterial drug combinations that they felt to be of public health importance. So the two most important findings of this report are really that, one, very high rates of resistance have been observed in all regions in common bacteria that cause common infections. Second was that many gaps exist in information on pathogens, surveillance, and resistance, and overall surveillance of antimicrobial resistance is not coordinated nor harmonized. But despite the limitations of the current surveillance, it still was very clear that antimicrobial resistance has reached alarming levels in many parts of the world, and they say there's an urgent need to coordinate to address those gaps, and the WHO is working on a global action plan. So resistance develops when an organism no longer responds to a drug to which it was originally sensitive, which means that our standard treatments no longer work, making infections more difficult or maybe even impossible to control. Resistance is such a serious problem that is threatening the achievements of modern medicine, and a post-antibiotic era in which common infections and minor injuries can kill is a very real possibility for the 21st century. So in addition to the issue of antimicrobial resistance, the pipeline for new antimicrobials is dry. So pharmaceutical companies are just really not investing in the research and development of new antimicrobials, and none of the few antimicrobials that are in later stages of clinical development are designed to treat the most invasive and drug-resistant pathogens. So from 1983 to 2007, the FDA reported a 75% decrease in the approval of antimicrobials, which is huge. So to try to counter this decline, the IDSA has come up with the 10 by 20 initiative. So this initiative is seeking global commitment to create an antibiotic research and development enterprise that will be powerful enough to produce 10 new systemic antibiotics by the year 2020. They say this effort has potential to save thousands of lives each year, and to achieve this goal, the IDSA is working with a broad range of stakeholders in the US and both globally. So I hope I've convinced you that antimicrobial stewardship is really important, and one of the things that we can do in our own health center to improve antimicrobial use is through antimicrobial stewardship. So as I mentioned earlier, IDSA and SHEA published these guidelines for creating and developing an antimicrobial stewardship program in 2007. And in these guidelines, they really focused in on 2 core strategies of a stewardship program that really provide that foundation. So the first being prospective audit of antimicrobial use with direct interaction and feedback to the prescriber. This can result in reduced inappropriate antimicrobial use, and it also allows an opportunity for prescriber education. The second core strategy identified in these guidelines was formulary restriction and pre-authorization, which can lead to immediate and significant results in antimicrobial use. Although this method, the effect on resistance is a little bit less clear, and you don't have that opportunity for education as you do with prospective audit with feedback. The guideline also outlines supplemental strategies. So education is an essential foundation of every stewardship program. Evidence-based guidelines that are based on local resistance patterns can help to improve antimicrobial use. Having order forms can help facilitate the implementation of practice guidelines. Continuing excessively broad therapy contributes to the selection of antimicrobial resistant pathogens. So streamlining empiric therapy can help to target the causative pathogen and also result in decreased antimicrobial exposure. Dose optimization based on patient characteristics, the organism you're treating, the site of infection, pharmacokinetics and pharmacodynamics is an important part of stewardship, and also having some sort of a systematic plan to convert from IV to oral can help reduce length of stay and, again, potential complications due to IV access. So I'm just going to talk a little bit about what's been done to date at the IWK. So we began by just educating ourselves. So two pharmacists, myself and another pharmacist, were appointed to try to start to do some of the legwork to get this program up and running. So the first thing we did was we completed 2 stewardship certificate programs through MAD-ID, so both a basic and advanced. And these programs included an online, live, and clinical component. So from there, we took that information we acquired and we developed a proposal or a business case for antimicrobial stewardship at the IWK. Then we went on to present this proposal to key stakeholders to ensure we had buy-in to move forward with this program. From there, after receiving the buy-in and support, we formed our antimicrobial subcommittee. So this committee functions as a subcommittee to D&T with obviously a focus on antimicrobial agents. And the committee includes ID physicians, pharmacists, infection prevention and control, and the ID clinic nurse. So forming this committee ensured that we had a forum to review all of the antimicrobial policies and guidelines and so on, but it was also a way to develop and foster a relationship with the core members of our stewardship team. So our next step was to begin developing resources for antimicrobial use and also review those resources that we already had available to us in our health center. Because as identified in the guidelines, evidence-based resources and guidelines that encourage appropriate use are one of the important supplemental strategies. So this is just a list of some of the completed projects that we've done. I'm not going to go over it in great detail, but we've done some drug reviews, mainly targeting some of the broader spectrum reserved drugs to make sure that we had appropriate indications, dosing, that the reserve status was appropriate and actually being followed by prescribers. We were able to bring the dispensing of outpatient tuberculosis medications to the inpatient pharmacy, which resulted in easier access for families and improved compliance. And we also developed lots of guidelines and order forms and resources. But we're really excited about where the program is going in the future and what our future plans are. So like I mentioned earlier, prospective audit with feedback is really one of the core strategies outlined in the IDSA guidelines. So that's where we are headed. So a research project is just getting underway in the emergency department here. So the physicians there expressed that they'd like to learn more about their prescribing patterns for the outpatient management of UTIs, because they have a sense that maybe their current practice is varied and might not reflect the best available evidence. So we're going to review those treatment patterns as well as the literature, and once this is complete, we'll develop a clinical treatment algorithm to be followed in the emergency room for outpatient treatment of UTIs. The next thing that we're very excited about is that we are currently recruiting for a full-time antimicrobial stewardship pharmacist, and this pharmacist will work to advance and formalize our stewardship program. So they'll begin monitoring patients and collaborating with the prescribing physician, the ID team, as well as the patient's healthcare team to optimize antimicrobial therapy and really use that prospective audit with feedback approach. And last thing they will be doing is identifying and measuring outcomes. So this is a really important step to determine the impact that your stewardship program is having. So outcomes can be divided into 4 broad categories. So first would be patient outcomes. So what's really important to the patient? So we might be looking at things like duration of hospitalization or clinical response rate. Next would be microbiology outcomes, so really focusing in on resistance or maybe even infection rates due to a specific organism. Third would be the impact on antimicrobial use, so maybe looking at oral versus IV, a change in overall prescribing, duration of therapy. And last, of course, is cost, which unfortunately is often the easiest outcome to measure, but always the least useful. So that is where we stand at the IWK. And now I'm happy to hand it over to Karen and Ashley, who are going to talk a little bit more about the evidence in antimicrobial stewardship and also with what's been going on at BC Children's Hospital.
Great, thank you, Gina. We actually, we did have a question come in during your presentation, and if you'd like I could ask it to you now. It's from Gayla. She's asking, and I'm going to try my best to pronounce this, should vancomycin, when indicated, be infused 120 to 60 minutes prior to cut? I'm not sure if I pronounced that correctly.
Oh, I'm assuming it's like surgical prophylaxis?
Your guess is better than mine, I think. Yes, she said yes, for prophylaxis, yes.
Okay. To be honest, I'm not sure that I have those exact numbers right in front of me. Maybe Karen or Ashley could speak to that, but.
This is Ashley. I also don't have those numbers in front of me.
Okay. Okay, well, we will move on to Ashley's presentation. I'm just going to hand control over to you, Karen. It should be coming your way now. And just as Gayla did, just my opportunity to remind everybody that you can ask questions just in the right-hand side, and we'll get to them just at the end of the presentation. Great, and we see your slides, so take it away, Ashley.
Okay, this is Ashley now. Thanks, Gina. Basically, Karen and I just wanted to talk a little bit further about antimicrobial stewardship, particularly about program implementation strategies, challenges, and some of our reflections after about a year of our program here at BC Children's Hospital. So, a little bit of background about BC Children's Hospital. It's a 180-bed tertiary care academic teaching hospital. It's the main referral center for pediatrics in the province of British Columbia. And we have a 60-bed NICU with a 22-bed PICU and a 24-bed oncology unit. We just began our antimicrobial stewardship program this past September. The structure, I won't go that much into detail other than to point out that within the health authority that BC Children's Hospital falls under is called PHSA, or the Provincial Health Services Authority. And so the Antimicrobial Stewardship Committee functions at an umbrella level for 3 different hospitals: the BC Cancer Agency, BC Women's, and BC Children's. What Karen and I particularly work on, although I cover those 2 other hospitals, Karen and I particularly cover BC Children's, and the reason why I'm pointing that out is just because there are unique aspects to stewardship in the pediatric population that are very different from those in the adult population, and so it really requires a little bit of dedicated people to actually focus on the pediatric elements of stewardship. So our particular stewardship team, and this model is replicated in centers in the United States as well as a few other centers in Canada in terms of who makes up a stewardship team. So I myself am a pediatric infectious disease physician. Karen Ng, who really is the backbone of our program, is a clinical pharmacist and the lead for stewardship. We have Dr. Simon Dobson, who's also an infectious disease specialist, who also serves on our committee, and then another pharmacy clinical leader, Dawn Hamilton. We also have other members of the team who are really key parts of the team. Dr. Peter Tilley, who's a medical microbiologist, and then a few champions in high-use antibiotic areas. So a PICU champion, Dr. Srinivas Murthy, and Dr. Joseph Ting in the NICU. And we do have the support of our entire infectious diseases faculty who do take part daily in the audit and feedback. We also have a small amount of IT support that helps us with data entry and those kinds of things. As Gina mentioned, and I won't go too much further into detail about the guidelines that the IDSA, the Infectious Disease Society of America, put out in 2007, which really was a template for guiding the implementation of stewardship programs. Some of the activities that they point out in those guidelines include prospective audit and feedback, which Gina spoke about, prior approval and drug formulary restrictions, automatic stop dates, passive education, so things like didactic lectures and written material, dose optimization of antibiotics, de-escalation of therapy once you know your culture results and your sensitivity results, and then IV to PO switches. They also discuss in those guidelines certain strategies to help adapt your particular stewardship program to your the particular culture in your institution. And so to be thinking about the local culture and attitudes, and these include the impacts of a perceived loss of prescriber autonomy, and to review whether inappropriate antimicrobial use generally occurs at either the start or at the continuation of therapy. And so to have some local knowledge about where some of the challenges are with regard to antibiotic prescribing in your own institution. And for us at BC Children's, that also took us to a place where we wanted to think about where our places of high use antibiotics were, where our places for our big gun antibiotics primarily were. And so that we were starting off, at least in places that used big gun antibiotics and used a lot of them, which brought us mostly to our critical care units. They also recommend assessing your available resources, obviously, and then again to start with low-hanging fruit and evaluate the worst offenders is how they put it. So a few of their outlines in terms of pros and cons of stewardship strategies. So with regard to the daily audit and feedback, obviously the pro is that it provides active education around actual patients. So it provides education to the whole care team of that particular patient, and it does it in real time. A con is that it lacks impact at prescription initiation, and there can be delays depending on what your coverage is, delays over evenings and weekends. In terms of formulary restrictions, it is quite effective at decreasing use of particular antimicrobials if you're concerned about a particular agent. And then the con being the sense of a loss of prescriber autonomy, and sometimes there's quite a lot of resistance in that regard. In terms of clinical pathways and guidelines, the pro is that this maintains prescriber autonomy and alters and does have impact in altering prescribing behavior. And unfortunately, though, it does require active intervention and constant surveillance as to whether those guidelines are up to date, and also some thinking about what happens when the guidelines actually aren't followed. And then passive education again, the pro being that it does benefit the promotion of stewardship and the increased knowledge around stewardship. And then the con is that it obviously is labor intensive, and it's often difficult to actually capture all the clinicians in a hospital. So in particular, some of our strategies at BC Children's, a big important aspect for us was the idea of collaboration. BC Children's is not a hugely large place in the sense that we are the tertiary center for the province, but most people, know each other in various departments and divisions, and we didn't want the AMS team to be taken and perceived as sort of the enemy number one, and as taking away your antibiotics, and so perceived in sort of a negative way. So we really wanted to go about it with a spirit of collaboration. We implemented a daily prospective audit and feedback program, and that's run by Karen. This focuses primarily on providing daily review of patients. Karen's going to go on a little bit more about the detail of that, but daily review of patients, review of more complicated cases with the infectious disease team, and then a providing of recommendations to the various clinical teams that those patients are under afterwards. Dose optimization, and various educational activities, including the development of various guidelines. Our biggest set of guidelines has been our empiric antibiotic guidelines that we basically will review on an annual basis based on new evidence. So our empiric antibiotic guidelines actually came out before this stewardship program started in September, so the year before in 2012, and then we've just done the annual review this past year on them to reflect new evidence. And then we also are involved with various research and surveillance of antimicrobial use, particularly in high usage areas. We have some major projects going on in our NICU in terms of auditing use, and we have some other projects that we'll talk about in terms of our surgical prophylaxis. And then our ongoing review of our formulary and the antibiotics on our formulary. So a big aspect of our collaborative approach was to basically identify champions in various areas. And so these have either been pharmacists or physicians that have an interest in infectious diseases, may or may not have formal specialization. Most of them don't in infectious diseases, but maybe people who have identified themselves through their research interests in having an interest in ideas around antibiotics or infectious diseases. So we have identified, as said before, an NICU champion as well as a PICU champion, and are just in the course of identifying an oncology champion. Again, reflecting places where we use a lot of big gun antibiotics. We have found that this has allowed for better acceptance of particularly our audit and feedback recommendations, because it has created more of a team-like atmosphere that we're all taking care of these patients together, not like we're the antibiotic police telling you what to do. And we've also found that this has also expanded our opportunities for research when we've had this collaborative approach, because we're able to work with these teams in the various divisions to come up with interesting questions and projects. We can't emphasize enough how important the microbiology collaboration is. The fact that we have a microbiologist on our committee that meets weekly is really key, because the microbiology piece is so important with regard to stewardship, and One example is that our microbiology lab has recently got a MALDI-TOF, which is essentially a laser technology that can identify culture results in a much more timely fashion than our traditional culture methods. And so what this allows us to do is to basically have earlier identification of the organism and thus hopefully earlier susceptibility results and thus earlier de-escalation to a more narrow spectrum antibiotic. Right now we're currently involved in actually formally collecting that information as to how much of an impact our MALDI-TOF is having with our stewardship activities on optimal, on time to optimal antibiotic therapy. But all indications in the literature in adult hospitals is that it has fairly significant reductions in both hospital stay as well as in time to optimal therapy, in the range of about pre-MALDI-TOF 80-something hours to about 23 hours in terms of the time it takes for a patient to be put on optimal therapy. The other big role of the microbiology lab in regard to stewardship is the production of antibiograms. So these are, for those that aren't familiar with antibiograms, they are your list of cumulative susceptibilities to various organisms over in our situation, it's over a 3-year period. So letting us know which antibiotics are sensitive to any particular organism, and so you get to know your own local resistance patterns, and this makes big differences when you're trying to come up with locally guided clinical pathways and recommendations. So can't emphasize that collaboration enough, as well as I said, the NICU and PICU, as well as we're collaborating with our general surgery team in terms of our surgical prophylaxis, trying to improve that. And then we're just in the course of beginning our oncology collaboration. In addition, in British Columbia, we also are trying as a province to bring together all of the health authorities within British Columbia to try and come up with a more coordinated approach to stewardship as a province. And basically what this looks like at the moment is a teleconference every few weeks that brings together, again, representatives from most of the health authorities that represent all of the hospitals within British Columbia to try and have common clinical pathways and essentially this whole idea of sort of not reinventing the wheel, that we can pull our experience and for those of us in pediatrics, it also allows us to have a voice at the table in terms of making sure that the pediatric population and the various uniquenesses of antibiotics when it comes to children aren't forgotten. So basically, in terms of the primary goals, and Gina went into this a little bit, but you know, our particular goals are basically to optimize clinical outcomes, minimize patient-specific and population-level negative consequences of antimicrobials, reduce resistance. Again, this is usually seen over the long run, and promote antimicrobial stewardship principles. Obviously, the secondary goals, although much more important from our administrative team's point of view, have been costs. And although this, you know, presents challenges in terms of how one measures costs, and particularly when it comes to pediatrics, the cost differences can be, you know, not the glorified numbers that you can see in adult hospitals, because the general costs are less. but we have seen decreases in our antibiotic costs even over less than a year's worth of stewardship. In terms of how to measure the results of your stewardship program, again, this gets into the unique situation of pediatrics. So generally in terms of how one measures antibiotic use, in a pediatric population, it's definitely days of therapy or number of doses over 1,000 patient days, as opposed to using what's done in adult hospitals primarily, or adult stewardship programs, which is DDD, or defined daily dose, because of the fact that the dosage in pediatrics is by weight. The defined daily dose doesn't really work out in a pediatric population. We also collect and have continual surveillance over our audit and feedback activity, and Karen will go on further about this. And we monitor the percentage compliance with our recommendations to get a sense as to which areas we need to continue to work on. We're also looking at time to effective and optimal therapy, so whether the time to the patient being on optimal therapy has been reduced with our stewardship activities, as well as our microbiological technical changes. And then over the long term, we obviously want to measure our resistance rates. And again, usually in most of the studies in the literature, this is somewhat difficult to show, but is probably going to be possible to show over a longer period of time. And then again, our incidence of hospital-acquired C. difficile, which in the pediatric population is primarily in the oncology or immunocompromised population, but it is something that can be measured.
So I'll take over from here. Thank you, Ashley. So I'm Karen. I'm the pharmacist on the team, and as I was introduced, I have started with the team since September, and this was also the time when we started our daily prospective audit and feedback process, which we found to be the core of our program in terms of daily interactions with the prescribers. So this has since evolved quite a bit over the past 8 months, and I'll share some of that experience with you. It is a pharmacist-driven process, which is in line with what guidelines recommend and what many other centers are doing. There have been studies that show that pharmacists have a better impact compared to infectious diseases fellows in the study, that pharmacists were observed to have improved outcomes in terms of doing audit and feedback, largely because it's quite in line with what our previous duties were. As a clinical pharmacist, many of us had already been doing antimicrobial stewardship before this was even termed to be a program. So it is in line with what many other teams are doing and using a pharmacist there. One of the biggest, most important lessons we've learned over the past 8 months in doing this is that audit and feedback is really teamwork driven. It's far more effective when we embrace teamwork. And if you imagine just one clinical pharmacist having to audit all the patients in the hospital, it can be initially quite overwhelming. There are many teams that you need to be dealing with, many different physicians, and that can be difficult to stay on top of all of that. But what we've found is that it's important to be resourceful and use resources that we already have in place, which are clinical pharmacists that are already involved in the teams and round with the teams every day. So we've found that we can connect with these clinical pharmacists every day in order to get sort of a quick outline of how their patients
are doing. They can let us know what the important issues they have had in terms of antimicrobial use during rounds, and they're able to bring some of the insight that the team has discussed during rounds about antimicrobial use, because sometimes that's not always apparent through chart notes, and you do want to hear about the discussions that they've had in debating the different issues in antimicrobial use. What we've found with doing this is that really this is a win-win situation for both of us, in myself as being an AMS pharmacist and for all of the other clinical pharmacists, in that it brings information back and forth both ways. So while they're able to help me identify patients to target and antimicrobial stewardship issues, I'm also able to give them information in terms of their questions about antibiotics and their infectious diseases issues with their teams, and they're able to pass on these questions from their teams to me, which I then can also pass on to the infectious diseases team and give them that feedback and education on. So we found that this has been a really valuable partnership. And on top of all of this, I also bring feedback back to the clinical pharmacist as well as to the team, and this really helped to link all of us together in doing antimicrobial stewardship, and has really helped me to be able to be effective in being able to see and know about all patients in the hospital and know about all of the infectious diseases issues that we have every single day. So in how I do audit and feedback, the first part is effective patient screening. So the pharmacy system that we use here is Centricity or BDM, and we've worked with our drug use evaluation pharmacist to generate an automated report every day of all inpatients on any antimicrobials on the pharmacy databases, and I get this report every day and I can review all patients. The only patients we exclude are patients in the emergency department and also cystic fibrosis patients, because they have a specialized team looking after their antimicrobials, and we audit all antimicrobials, and all orders are reviewed within 24 hours Monday to Friday. And as I had mentioned, another very important method for knowing how I should spend my time is through ward clinical pharmacists, because they can identify the patients who would most benefit from our stewardship efforts. We also liaise with microbiology. As Ashley had said, it's been a very fruitful liaison with them. On a day-to-day basis, they're able to identify patients with positive blood cultures to us so that we can target these more acute patients, and also they help to assist with microbiology-related questions. We also liaise with infection control, and they identify patients with infectious diseases issues, communicable diseases, positive cultures, and we work hand in hand there. So every day I meet with the infectious diseases team. There are other antimicrobial stewardship programs where the antimicrobial stewardship physician takes an active role in audit and feedback, but we knew with Ashley having limited time in the program and having to split her time between the different facilities in our PHSA, we knew we couldn't have that every day. So we structured it so that we, as the pharmacist on the team, I connect with infectious diseases to get all of these complicated questions that I have every day answered and have that expert opinion. So I round with them every day and can bring these questions to them, and they can help me with feedback before I bring this back to the teams. So this is an overview of our stats over the past few months, and the first line is just the number of days of stewardship activity. My position isn't backfilled, so you can see it isn't on certain days when it's a stat holiday, when I'm not on site. Unfortunately, those days we don't have stewardship activity, but we do have it on most days of the week. And the number of patients that we've audited per day has been
steadily increasing, and that's a reflection of the growth of our program and how we've evolved, in that initially we were targeting only certain wards, and now we audit all patients. That's also reflected in the number of antimicrobials that we audit per day, in that we've expanded to all antimicrobials rather than looking at just target antimicrobials. And in terms of patient interventions and the recommendations that I've made, that's also grown because we are now auditing more. You can see our acceptance rates are generally in the 80 to 90% range, which is in line with other hospitals. And we also keep track of all of the recommendations that are not accepted, and we keep a detailed account as to why, so that we can continually learn from our process. I've made a pie chart of just our audit and feedback activity, and you can see that we have the highest activity on the general medicine wards, and also on neurology, surgery, and most surprisingly, although we read from adult hospital evidence of their audit and feedback. Usually they have more activity in the PICU, and we haven't found that to be the case, which is something that we've adapted to, in that in learning that they've actually required less help in terms of audit and feedback, in that they are using their antimicrobials more appropriately than we've seen in other hospitals. This is a breakdown of the intervention types that we've been making. You can see that the highest number is actually in discontinuation of antimicrobials, followed by IV to PO step down. We have a lower number of optimization of doses because this is mainly a responsibility of the ward pharmacist, and I don't capture what they do on a day-to-day basis. So these numbers are probably higher. We do actually look at every clinical pharmacist and all of their activity related to antimicrobial use. Other interventions we found that have been useful is to recommend ID consults in complicated patients, and that's been nice that we are able to liaise with the ID team every day. In terms of looking at which antimicrobials to steward, when we started and read other guidelines, we noted that most adult ASPs do target specific antimicrobials, and that's what we had initially started off doing. Considerations in what to target, generally we're thinking of the more broad spectrum antimicrobials and the ones that have activity against multi-drug resistant organisms that we want to reserve for those purposes. We also want to consider cost, usage patterns, and then also which antimicrobials have higher rates of error associated with that. So we had started off with a list of antimicrobials, and as we went on, we noticed that there was a good activity with other antimicrobials that we also needed to audit. So we've expanded now to auditing all antimicrobials, both parenteral antimicrobials and oral. And you can see from this breakdown of which antimicrobials our stats fall under that not all of them would have actually been captured by your usual target list. You can see that our third highest interventions is on first-generation cephalosporins, largely because it's used heavily in prophylaxis in surgical patients, but also amoxicillin and ampicillin falls fourth on this list. So again, this is to show that maybe target antimicrobials aren't exactly the way to go in our pediatric patients, and there is a benefit in broadening some of this to what you actually see in the hospital. And what we can give some feedback on. We've been tracking our acceptance rates by team, and this is a reflection of acceptance rates by wards. Most of them, again, are in the range of about 80 to 90%, but we have noticed that our worst rates are actually in the NICU, where you can see about a 64% acceptance rate only there, and that is our worst, and that has been consistent, although that's been slowly improving. So we have picked out several areas that we need to concentrate more on and we have the most difficulty with. So there are unique challenges in the NICU, and to me that is a more difficult area to steward, largely because the patients there are the most fragile of the entire hospital, and there's serious consequences both of under and over treatment because they don't have a well-developed immune system. But at the same time, use of antimicrobials can have serious consequences, some that we know of and many that we probably don't even know of yet. It's very hard to differentiate what their symptoms are due to, and often it's hard to find definitive infectious pathology in these patients, and so it's difficult to steward in those terms. And also they have unique PK and PD considerations in these patients, and largely because there's limited evidence and guidelines. Secondly, we've also found that there's lower acceptance rates in areas where there's less regular communication, where there's not regular rounds, and so that ASP is not so much of a regular routine. So to target some of this, we've looked at a retrospective audit of antimicrobial use in the NICU just to see where we can have a benefit in. And we basically looked at the past 3 years before antimicrobial stewardship, looking at some target antimicrobials here that we knew were in higher use. And we evaluated this based on the CDC 12-step campaign, working in collaboration with a neonatologist. And we have found that there are many courses of inappropriate use where we could have an impact. So just in general, based on this this audit, we did find that, although diagnosis can be difficult, these patients are more difficult to steward. There are opportunities just based on core principles of needing to de-escalate, streamlining, and recognizing when to step down based on culture and sensitivity reports. In terms of feedback, our primary goal is to always try to have a face-to-face or verbal communication with physicians just to establish that collaboration. And the other method is also to use clinical pharmacists to help make these suggestions back to their team during their daily rounds. And also, thirdly, is written communication in the chart, where we have tried to formulate a more standardized form to put in the chart just to summarize our recommendations. We do work with some support from IT and decision support, and hospitals have different methods of doing audit and feedback, and what we are trying to develop now is to establish a database using Microsoft Access to help us with audit and feedback, and this allows me to keep track of the issues for patients and their antimicrobials and history. Other initiatives include, again, collaboration with microbiologists to adjust susceptibility breakpoints based on PK/PD considerations in adults, and also updating antibiograms. And we're also working on trying to make ward-specific antibiograms specifically for NICU. We have generated a new update of cumulative antibiogram and presented in a more unique fashion than before, where it is now grouped according to organism. We've also been working on an update of our empiric antibiotic guidelines, and we will have that out by June. And one of the more useful ways to disseminate this is via lanyard cards to clinicians, which we've had lots of positive feedback on. Other initiatives include, again, just doing educational events and presentations, formulary reviews, guidelines, order sets. We have a number of NICU projects because that has been noted to be a target population, surgical prophylaxis empyema project, and we're also trying to establish a pediatric antimicrobial stewardship website. So just in conclusion, some of the lessons we've learned in adapting antimicrobial stewardship to pediatrics include considering the unique challenges in special populations, namely in ICU and also other patients such as short gut patients, patients with congenital syndromes that impact antimicrobial use, and also knowing that target antimicrobials in pediatrics may be different than what's seen in the adult population, and recognizing that there's limited evidence, which then leads to greater variability, and which also in turn makes collaboration and discussion more important in recognizing some of that variability. Outcome measures also require adaptation, as Ashley has discussed. And lastly, reflections on our program include just the importance of adapting strategies to your hospital. It's important to recognize and understand the culture of the hospital and what works best, and also knowing what problems there are in antimicrobial use there and knowing what to target. This requires continual reassessment, and we've been readjusting our strategies initiatives over the past 8 months, and this is to be continued for sure. And lastly, we must not forget that antimicrobial stewardship is a unique program in that the humanistic factor is major, and we do need to consider how to best collaborate and have others accept our recommendations. And lastly, data collection is absolutely crucial. We've been collecting data both of just prospectively on our activity, but also retrospective data collection to know where we can have an impact. So that is a large role in our program. So that concludes our presentation for today. Thank you very much for inviting us. We do welcome any questions, and we're sorry that we are a little bit over time at this point.
Okay, great. Thank you so much, Karen. We actually did have a question come in during Ashley's portion of the presentation. Both of you can speak to it, and Gina can jump in as well. It's from Nadia. She wants to know if you recommend the presence of an infection control nurse on the committee.
So this is Ashley. Yeah, I didn't actually mention infection control. We don't have an infection control representative on our particular committee. Primarily, though, that reflects the structure at BC Children's Hospital, where the microbiologists actually cover our infection control, and so the presence of Dr. Peter Tilley, our microbiologist, actually does sort of represent infection control. So it brings up a really good point, because I actually think that an infection control nurse or representative from the medical side of infection control would be a really nice contributor to the stewardship team. Again, because they are usually keenly aware of what is currently in your hospital from an infectious disease patient perspective, and have their finger on the pulse in terms of what's actually going on from an infectious diseases point of view in your particular institution. So I think they have a lot to contribute.
Great, okay, and Nadia says thank you very much for that answer. And we have another question from Bonita. She's wondering if you can tell us what type of audit tools you use for your programs.
Sure. So this is Karen. In terms of audit tools, we obviously use our pharmacy database, and we do have Cerner, but we are due to have antimicrobial stewardship capabilities for our Cerner program later this year. I haven't seen that yet, but that is something that I know is coming. So as I mentioned, we are working with decision support to build an antimicrobial stewardship database that I have been using and trialing over the past couple months or so. We are using Microsoft Access, and we load pharmacy data onto there every day, and I use that to keep track of my recommendations, my assessment notes, and that is what generates the chart note that gets printed out. So we've been working on that. It is still a work in progress, but one of the major benefits of actually having a database is that it allows you to track previous notes, because we have many patients who are readmitted or have continuous issues, and this allows me to look back on their history and be able to track that faster.
Okay, I think judging by the time, we probably should wrap up at this point. So I really want to thank our presenters so much, because it's been really fascinating. I think that if there are other questions, it would be ideal to either send them by email to the presenters directly, if they don't mind, or channel them through Lisa or Sam in order to get your questions answered. But I think as far as an overall presentation, this has been fantastic, because we're all at varying points in our implementation of ASP programs, and it's there's something to take away from everyone. On behalf of Darlene and the rest of the CAFC team, I do want to thank our presenters for their great presentation, and just remind everybody that the next Patient Safety Collaborative call is on June 27th. If you have any ideas or suggestions for presentations, anything your organization would even like to share, please contact Lisa